All right, good afternoon. My name is Candice Perez. I'm a paramedic and we're going to go over basic arrhythmias. I'm also an ACES and college instructor. We're going to go over the American Heart Association basic EKG arrhythmia course. So we're going to explain and understand anatomy and basic electrophysiology, explain normal EKG meta-image, and recognize and understand basic arrhythmias. We're going to go over anatomy, electrophysiology, baseline EKG parameters, as well as our normal rhythms and our abnormal rhythms, our basic arrhythmia concepts, as well as our basic arrhythmia cardiac analogy and understanding of electrophysiology. Anatomy of the heart. So we have the aorta, the left atrium, right atrium. We have the you write a tricycle before you write a bicycle. This is the tricuspid valve, the mitral valve, right ventricle, and left ventricle. Know your anatomy of the heart, know the chambers and how the blood goes through. So blood is returned to the heart through the inferior and superior vena cava into the right atrium. Then once it's pumped into the right ventricle, is pumped into the pulmonary arteries where it's oxygenated. It then returns from the artery here to the left atrium, pumped into the left ventricle, and out through the tricuspid valve. Our conduction system anatomy, you have the SA node. It starts at the top. That's the right atrium. We have the internodal pathway, the AV node, also called the common bundle hinge or the AV junction. We have our left bundle branch and our right bundle branch. So we talk about left and right bundle branch blocks, that's what we mean. And here's your Purkinje system that supply electrical activity to the ventricle. So pacemakers of our heart. Your standard pacemaker of the heart right here is your sinus node rhythm. This sinus node fires at a rate of 60 to 100 beats per minute. Standard sinus rhythms, this is why we call this sinus rhythm, it goes from 60 to 100 beats per minute. The impulse next travels to the AV junction, where the AV node fires at a rate of 40 to 60 beats per minute. And these are our junctional cells. So the arrhythmias that originate from the AV junction could be AV nodal blocks or junctional rhythms. In junctional rhythms, the P is absent or inverted. Your Purkinje system fires at a rate of 30 to 40 beats per minute. Okay, so a lot of your ventricular rhythms you'll see at that rate. All right, anatomy of your EKG, you have your P wave. Sorry, I went back too far. You have your P wave, QRS, ST segment, and T wave. Your P wave is representative of atrial depolarization, which is contraction. Your PR interval is the filling of the atria to the ventricle. Your QRS is ventricular repolarization or contraction. And then we have our T wave, which is ventricular repolarization, and atrial repolarization is hidden in the T wave. So let's talk about our mean electrical vector, positive versus negative electron. So when the stimulus goes towards the positive electrode in the heart, you get a positive reflection on the EKG paper. When it goes away from the electrode, you get a negative reflection in the EKG paper. So that's how everybody's EKG can look differently depending on their electrophysiology, how big their heart is, and their history. The lines and calibration on your EKG paper. Remember, one small, tiny box is 0.04 of a second. One large box is 0.20 of a second. All right. One tiny red box from the top is equal to 1 millivolt, which is 1 millimeter. The standard PR interval should be 0.12 to 0.20 seconds. So it should be less than 5 boxes wide on your PR interval to be normal. Here's your QRS, that should be less than 3 boxes wide or 0.12 seconds wide. And your QT interval is corrected for heart rate. So if the rhythm is faster, the QT interval is going to be smaller. If it's slower, the QT interval is going to be longer. Heart rate estimation. So we can take a 6-second EKG strand, find out where the R wave falls closest to a red line, and then we count the next line: 300, 150, 100, 75, 60, and it falls right here at 75. So it's about 75 beats per minute. We can also do the multiplication method where we count on a 6-second strip and times by 10. All right. Standard monitoring leads. Lead 1, in lead 1, the positive electrode is located on the left arm and the negative electrode is located on the right arm. So when the stimulus goes from negative to positive, you have a positive deflection on your EKG paper. And then your left leg is always the ground. In lead 2, the positive electrode is now the left leg. And the negative electrode is going to be on the right arm. Right? Yeah, right arm. This one, right arm. And the ground is the left arm. So lead 2, this is our rhythm that gives our best view of the heart. This is looking down at the heart. This is the rhythm that we look at it for all EKG rhythms and dysrhythmias. And this is what we see in the background of the EKG monitor going. That's the rhythm we're looking at. So when we're analyzing dysrhythmias, we always want to look in lead 2. Lead 3, in lead 3, the positive electrode is located on the left leg, while the negative electrode is located on the left arm. And our 12 lead gives a bigger picture of the heart. So with your 12 lead, you have leads 1, 2, and 3, as well as precordial leads, which is the 1, 2, 3, 4, 5, and 6, and augmented leads, which is AVR, AVL, AVF. All right. We talk about AVR. AVR is augmented with right lead. That should always be upside down. AVL, augmented left and augmented foot. All right, then you have your precordial leads, V1 through V6, which look at the anterior and lateral surfaces of the heart. All right, so when we talk about leads 2, 3, and AVF, that's the inferior wall. Leads 1 and AVL is high lateral. V1 and V2 is septal. V3 and V4 is anterior. And 5 and V6 is lateral. So we're looking at an EKG, there's 12 leads, and let's say the patient is having ST elevations in leads 2, 3, and AVF. Those leads correspond to the inferior wall of the heart. The inferior wall of the heart is innervated by the right coronary artery, and that's the artery that cardiac cath is going to go in with their probe and clear the blockage. That's why it's important that we have an accurate EKG and a clean presentation of EKG, and we've diagnosed that STEMI because we have 90 minutes from hospital ground to get them on the cardiac cath table. 90 minutes is the goal. Basic arrhythmia is rhythm strip interpretations. We're always going to do our 4-step approach to EKG interpretation. The EKG rhythms will never look alike. It's wrong for you to say, oh, it doesn't look like VFib, it doesn't look like VTAC. Why? Because you haven't analyzed the rhythm, and we're going to teach you how to analyze the rhythm. So you want to look at rate. Is the rate normal? Meaning 60 to 100 beats per minute is normal. Is it Brady? Less than 50 beats per minute. Is it tacky? Greater than 100 beats per minute. Remember, if it's SVT, supraventricular tachycardia, has to be greater than 150 beats per minute. PSVT, paroxysmal supraventricular tachycardia, will be greater than 299 beats per minute. The next thing you want to ask yourself is the rhythm regular or irregular? Are there P waves? And is each P wave related to a QRS with a one-to-one impulse induction? So you should have a P wave for every QRS and vice versa. They work together, they don't work apart. Is your QRS normal or wide? A normal QRS is less than 3 boxes wide. A wide QRS is greater than 5 boxes wide. So our arrhythmias have certain etiologies. We could have a disturbance in automaticity where the pacemaker speeds up and a new pacemaker may take over at a higher or lower rate. Remember, we have your SA node that fires at a rate of 60 to 100 beats per minute. If that node speeds up or fails to take over, your AV nodes will be next in line to take over for that rhythm. You have a disturbance in conduction. Slowing or block in conduction of electrical pulse, where it's blocked at like the AV nodal blocks, or a combination of both. We have re-entry rhythms mixed with a disturbance in automaticity. Normal sinus rhythm. It's normal because our rate is 60 to 100 beats per minute, like you see on the PowerPoint. Our rhythm is regular. P waves are present in upright and normal morphology, and there's a P for every QRS and vice versa with a one-to-one conduction rate. Usually no therapy is needed for this. This is normal. No therapy is needed. Sinus bradycardia. Everything else is normal, but the rate is less than 60 beats per minute. Our treatment is to treat the underlying cause of the bradycardia. So let's ask ourselves, what can cause bradycardia? Think about it. Hypoxia can cause bradycardia. So if we give oxygen or ventilate the patient using an ambu bag like we see here, we might get their rate up naturally without having to give medication. The medication of choice that we give for this to get it up, if it was sinus bradycardia and they're not responding to basic airway maneuvers, we give atropine 1 milligram. We can repeat that 1 milligram every 3 to 5 minutes for a total of 3 milligrams. If atropine doesn't work, we can do pacing. We can externally pace the patient. We can do epinephrine or dopamine as a vasopressor drip in an effort to increase their cardiac output and thus increasing their heart rate. Sinus tachycardia. So that's from 100 to 149. Anything greater than 150 is SVT. Everything's normal on sinus tachycardia. We can see the P, the Q, the R, the S, and the T. But it's really close together because it's occurring really, really fast.
IV class for Saturday.
Oh, the rest of the line.
She can't register. She said it's not letting her do it.
I'll call back when I'm done with this part.
I got you.
So therapies treat the underlying cause of the tachycardia. So what can cause the tachycardia? Let's think about it. Infection can cause tachycardia. Anxiety. Pain. So the theory is that if you treat the infection, the anxiety, and the pain, their tachycardia might go down. If it doesn't, then we will look for other reasons on why they're tachy. All right, self-assessment. You're going to write this in the chat for me. Tell me what are the rate and rhythms for A, B, and C. You answer that in the chat, and we're going to answer later on in our presentation. All right, so what is this rhythm right here? And we can count it. Let's count it because this seems to be a 6-second strip. We go 1, 2, 3, 4, 5, 6, 7, 8. So we have 8 complexes times by 10. This is 80 beats per minute. This is a normal sinus rhythm. But now if we have that rhythm with no pulse, what do we call that? A rhythm with no pulse, think about it. A rhythm with no pulse, we call that pulseless electrical activity, PEA. When we have PEA, we want to think about the underlying cause of the PEA. We will review our H's and T's and our cardiac arrest, like we call that our reversible causes. So we have 5 H's and 5 T's that we want to go over. You guys should already know that from your insulin curriculum, and we'll go over that later in the PowerPoint. Basic arrhythmias, supraventricular arrhythmias, premature atrial contraction, such as premature atrial beat, atrial premature beat, premature atrial complexes, atrial fibrillation, atrial flutter, or reentry tachycardia. So PAC is a premature atrial contraction. This is a contraction that is premature that interrupts the beat. When we look at this rhythm, about 1 to 3, about the 4th beat over, we see this beat here that kind of disturbs the regularity of the rhythm. So usually the sinus rate is sinus, however the rhythm is irregular because the PAC throws off the regularity of it. Treatment is directed at treating the underlying cause of the PAC. So if we don't know, we might do a good history and physical exam and get the patient a consultation to cardiac. All right, so a few things we learned about premature contractions. You want to think about, is the patient perfusing while they're having this premature contraction? If not, that could be a reason why they syncopize at work. Atrial fibrillation. In AFib, the rhythm is irregular. You can't really discern P waves. You can't really see it. Conduction's irregular. We want to slow the rate if possible and treat the underlying cause. So treatment for AFib or A-flutter, we could try calcium channel blockers, such as verapamil or cardizem. We could try beta blockers like metoprolol or labetalol to try to terminate this AFib rhythm. The same would be true for A-flutter. Our treatment for A-flutter would be the same thing: verapamil or cardizem as calcium channel blockers, or beta blockers, metoprolol or labetalol, to treat this. So this is a fast rate with an A-flutter. The difference between AFib and A-flutter is that you have flutter waves. It looks like shark fins, little mountainy type protrusions that we have here. So our treatment is directed as treating the underlying cause of the atrial flutter. So supraventricular tachycardia. Remember, that's that narrow complex tachycardia that's greater than 150 beats per minute. Typically, the patient's complaining of palpitations. Their heart's beating really, really fast. Palpitations. So patients complaining of palpitations, we're going to do a history physical exam, give vital signs, pulse oximetry, give oxygen, put them on a cardiac monitor. And if they're stable, we're going to try to do vague maneuvers to slow down that rate. So vague maneuvers you could try, you can tell them to bear down, do ice to the face, or they can blow through a straw or blow the plunger out of syringe. So you can have AV re-entry tachycardia. You can have AV nodal re-entry tachycardia, or you have atrial tachycardia, which is an atopic atrial foci, meaning the focus is coming from the atria. That's why it's atrial tachycardia. In re-entry tachycardia, this is a dual pathway, use the AV node, where it's coming back and forth. So is the QRS normal or wide for each? You know, it depends on where it's coming from. Pretty commonly, if it's some type of ventricular re-entry tachycardia, your QRS is going to be wide. So SVT, paroxysmal SVT. As you're watching the patient, they just speed up really, really fast. So we can do vague maneuvers. We can do adenosine if they're stable, right? Adenosine dose 6 milligrams, followed by 12. If they don't respond to the first dose of 6, fast IV flush with at least 10 cc's of normal saline, bolus. All right. If that doesn't work, we're going to do synchronized cardioversion. So we're going to synchronize on that R wave and deliver a shock at 50 to 100 joules if it's narrow, 100 to 200 joules of wire. Now we're going to need to make sure we sedate the patient, give some type of sedation. It can be morphine, it could be a benzodiazepine, it could be fentanyl. Something to take the edge off because this is a very, very painful procedure, synchronized cardiac rhythm. So we look at rhythm A. We have those flutter waves, right? Flutter waves. That's atrial flutter. B, you're like, oh my God, what's that? Analyze the rhythm. Is it regular? It is not. Do we have P waves? I cannot see P waves in that rhythm. So we can call this irregularly irregular. That's atrial fibrillation. Very commonly, patients who are diagnosed with AFib are on some type of blood thinner like warfarin or Coumadin or aspirin, because in AFib we're concerned about the blood stagnating in the atria and clotting. All right, your patient is unresponsive with a BP of 70/50. All right, first of all, that BP unstable. A systolic BP less than 90 is unstable. We want to maintain a BP at 90. 90 is our goal in normal situations. Greater than 90, stable. Less than 90, unstable. No longer are they in compensated shock, they're in decompensated shock. All right, and our rhythm here, SVT. Look how fast that's going. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So that's about 150. So it can be sinus tachycardia or borderline SVT. Our action would be is to treat and identify the underlying cause of the tachycardia. All right. Ventricular arrhythmias. We have premature ventricular contractions, ventricular tachycardia, VFib, asystole, and pulsus electrical activity on our next slide. All right. So in a premature ventricular contraction, as we talked about in premature atrial contractions, you can have a wide complex beat that's going to interrupt the normality of or the regularity of the EKG, and it's going to throw it off. Same thing with the PACs. Patients can syncopize if too much of these PACs and PVCs occur in a row together. So think about grandma having 3 of these PVCs that occur in a row, interrupts her heart, interrupts her flow. Now grandma collapses on the ground or syncopies at work. That's the reason why she's in the ED. All right, PVCs versus PACs. And PVCs is definitely coming from the ventricle. And PACs, your stimulus is coming from the atrium. That's why they're called that. This is your mechanism of PVCs and your Purkinje fibers. Purkinje fibers are what's in the ventricles, right? Those little things. All right, PVCs. We can have unifocal PVCs like we have here on number 1. You have unifocal PVCs occurring in bigeminy, which is every 2 beats or every other beat. All right. We have multifocal PVCs like we see in number 3. We can have VTAC, or what we call a run-on VTAC like we see in number 4. Number 4, when it's 3 or more PVCs in a row, we call that a run-on VTAC or VTAC. Torsades, that's your polymorphic VTAC, right? And your VTAC is your monomorphic VTAC. So your PVCs can occur in trigeminy, bigeminy, quadgeminy. It can be multifocal or unifocal. It can be in a couplet, which is 2 or 3 or more, which is a run-on VTAC. All right, monomorphic VTAC. That's your tombstones that you see there. That's the one that the EKG machine, the AED machine detects, and it's going to shock. This is cardiac. Normally cardiac arrest if they have no pulse and no breathing. If they have a pulse, we're going to do our tachycardia algorithm. If they have no pulse, we're going to do our CPR cardiac arrest algorithm. All right, we see no P waves. All we see is this one QRS, monomorphic in nature. That's why we call it VTAC. Polymorphic VTAC or torsades de points. This is coming from multiple foci in the ventricle, as you see in this picture on the slide. So you have multiple Purkinje fibers firing off, and they're not working together. This is bad. So treatment for polymorphic V-tach is going to be magnesium sulfate, 2 grams IV bolus. In addition to your cardiac arrest protocol, in addition to your epinephrine, 1 milligram in 3 to 5 minutes, in addition to your cardioversion, in addition to your CPR, and you're reviewing the reversible causes of cardiac arrest. VFib, normally this is cardiac arrest. They're dead, no pulse, no breathing. We're going to start CPR. We'll call the call, start CPR at a rate of 100 to 120 compressions per minute. All right? If this rhythm is shockable, so we're going to shock at 200 joules, shock the patient 200 joules, shock. We're going to get IV access. We're going to administer our first dose of medication. It's going to be epinephrine, 1 milligram, every 3 to 5 minutes. In a cardiac arrest, every 2 minutes you're pausing to check the rhythm. So in reality, you're giving epinephrine every 4-minute mark, which corresponds to every other CPR cycle. So if you give me epinephrine every CPR cycle, that's too frequently. You want to give it every other CPR cycle. With the immediate shock this patient, immediately shock this patient. Call the code team, get the code team there. All right, now we can have what we like to call here, we call this fine VFib, meaning instead of being a really big line, it's a little tiny line. So a big line would be coarse VFib, a small line could be fine VFib. Same thing, we're going to treat it, we're going to shock them. CPR, our cardiac arrest protocol. Assistantly, that's flat line, nothing is there. No P waves, no QRS. All we can do is CPR, epinephrine, no shock, and review the reversible causes, your 5 H's and 5 T's of your cardiac arrest algorithm. Why we do that? Because the reversible causes, if we reverse them, can reverse the system. All right. Pulses of electrical activity. What you have here is a rhythm with no pulse. Why no pulse? Because you have enough atrial pressure. There's not pressure in the system to produce a pulse. That's why we resume CPR, to help build up that pressure. So you want to identify and treat the underlying cause, do CPR, try vasopressors if needed, that would be epinephrine. Atrophy is not indicated in this protocol anymore. Scratch that off your slide. Number A, what's A here? A is regular and monomorphic in nature. That's monomorphic V-tach. Take a look at B here. In B, you have A, B, and C, which is different foci firing off. We call that your polymorphic V-tach. All right. You see this rhythm on the monitor while you're standing next to the patient. What would you do? Well, first, I hope you would check the pulse, because at the end of this rhythm right here, they're going into VFib. So you want to check the pulse. Ma'am, sir, are you okay? Check the pulse. No pulse, no breathing. We're going to activate our emergency response system and start CPR, beginning with compression first. We'll have somebody go get the AED, and we're going to tax the AED. All right, AV nodal blocks. They have our 1st degree, 2nd degree, and 3rd degree AV nodal blocks. So your incomplete blocks is a 1st degree block. This is our, we call this our type 1 winky block, Mobus 1. Our type 2, Mobus 2, is going to be your 2nd degree AV block type 2 or your 2nd degree AV block type 1. You can have a complete AV block, which would be a 3rd degree block, where you have no correlation between the atria and the ventricle. So, in a 1st degree heart block, the underlying rhythm is normally sinus, it's slow. We have 1 P wave, but the PR interval, like you see here in this picture, is always greater than 5 boxes, and it's constant. There's 1 P wave for each QRS, and vice versa, but the P wave is too far from each other. So that causes a delay in the atrio filling the ventricle, and that could be an issue for some patients. And that's your 1st degree AV block. All right, so we look at this EKG, it's regular. But each time we look, there's no maybe you can see my mouse here on the presentation. But each time here you see we're gonna need to long, left long, it's too far apart. So that's the first degree AV block. Excuse my stuttering. So second degree AV block type 1, Mogut's 1, Winky block phenomenon. In this, you have an underlying sinus rhythm where a P wave fails to periodically conduct. You have an increasing PR prolongation, as you see here in this diagram here. So it'll start at 0.10 seconds, 0.20 seconds, 0.50 seconds, 0.65 seconds, and then it drops. It loses the QRS altogether. What's important to understand is that atropine isn't always effective on high degree heart blocks, and we might have to do pacing or epinephrine or dopamine to try to get their rate up. But in the meantime, these patients, definitive care is they're going to need a pacemaker put in because their AV pacemaker is not functioning. Secondary AV block type 2. This rhythm is usually regular, except for the drop piece. There's no prolongation. Just out of nowhere, it drops 1 or 2 beats, as you see here on the diagram. Remember, atropine may not be effective on this rhythm, so we might want to consider pacing this, externally pacing this patient and getting them set up with a cardiac lab or EP to have a pacemaker put in, right? Third degree AV block with a junctional escape rhythm. How we know it's junctional escape? Look at that QRS there. It's narrow and it's just all over the place, right? And then we also have no atria or ventricular correlation. The atria is not working with the ventricle like it's supposed to be. This is a third degree heart block. Right. This is a third degree heart block with a ventricular escape complex. Why is the ventricular escape rhythm? Because you have a wide QRS like you see here in the diagram. However, the atria isn't working together with the ventricles. They're out of sync. They need to be in sync to work together. Are you going to tell me in the chat which types of blocks these are? Which type of block is 1? Which type of block is 2? Which type of block is 3? And what type of block is 4? You can put that in the chat. We'll talk about it later. So an athlete in the ED with this bradycardia rhythm, with this first degree heart block, probably going to do nothing. But if it's a diabetic woman in the ED with chest pain, definitely going to do something. Probably call cardiology, get a cardiology consult, get a 12-week EKG, and assess to monitor the patient, get a good history and physical exam. All right. We have a 78-year-old woman with altered mental status, blood pressure 80/60, an external pacemaker or pacer is not available. And they're in this rhythm, which what we see is a wide complex rhythm with no correlation. This is a third degree heart block with ventricular escape rhythm. All right. Pacer not available, so we're going to do a drip of epinephrine or dopamine. And we're going to titrate those doses of epinephrine and dopamine to the patient's systolic BP of at least 90. So pacing, we have transvenous pacemakers, ventricular, atrial, or dual chamber. So, ventricular pacemakers are in the ventricles, atrials in the atrial, dual chambers do both. So this is what it looks like an EKG that's being transcutaneous pacing, meaning we put the pads on the patient and we're transcutaneously pacing the patient. Ventricular pacemaker, how we know it's ventricular is that we have a little tiny spike like you see here, followed by a wide QRS. Always, 100% of the time, if it looks like that, tiny spike followed by wide QRS, the pacemaker is ventricular in origin. All right. Pacemaker malfunction, it should look like the top rhythm, but it looks like the bottom one. That's bad. It looks like the top because that's how it should be. You should have a spike followed by a wide QRS because the artificial pacemaker is taking over the role of the SA node. I know it doesn't look normal. They're not going to look normal with these EKGs, That's why you have to call cardiology and you have to assess the rhythm. So you can have a dual chamber pacemaker where it does both, atrial and ventricle. Cardioversion, synchronized cardioversion. You know, when we synchronize cardioversion, we're synchronizing on the R wave. So now the protocol says to use your manufacturer's recommendations for this stuff. You don't have to guess. If you don't know, use the manufacturer's recommendations for it. But what you can do is for initial defibrillation, if the QRS complex is narrow, we can do 50 to 100 beats per minute. I mean, 50 to 100 joules initially. If it's wide, we could try 100 joules. So how that works is that the wider the rhythm, the higher the dose you kind of want to go when you do synchronized cardioversion. All right, guys, any questions? You put it in the chat.